to tonight's webinar. First of all, thank you all for joining tonight's Postpartum Depression webinar by the Rockford Jewish Community Council in our effort to inform, educate, and prevent. I want to thank JOWMA for partnering with us on this very important project. First of all, let me introduce myself. My name is Esther Klein. I'm a birth doula and educator. I'm currently directing the Access Health Women's Division, which is a department of BPJCC. Being involved in women's health initiatives, specifically when it comes to pregnancy and birth, I've seen one too many women struggling with postpartum depression with very little access to the right resources. And that really pushed me to take the first steps in educating on postpartum depression and the prevention of it. Hence our webinar tonight. Tonight we'll have two panelists who will be giving you information on postpartum depression, whether it's for you or for someone you want to help. We'll go through like a formal presentation first, and then we'll take questions the last few minutes of the webinar. If you have any questions, please submit them to eklein@bpjcc.org. That's Klein, K-L-E-I-N @bpjcc.org. I'm going to put that email address in the chat box as well, so you can refer to that. I'm just going to wait one more minute, and then I'm going to give a brief introduction on Dr. Moses, and she'll take it from there. Okay, so I'm going to go ahead and introduce our first panelist, Dr. Tal Weinberger. Dr. Tal Weinberger, MD. I'm sorry, no, our first panelist is Dr. Denise Moses. I'm sorry for that. Denise Moses, MD, FACOG, is our board-certified OBGYN. Dr. Moses received her undergraduate degree at CUNY Brooklyn, medical degree at SUNY Downstate. She completed residency at Hofstra, North Shore LIJ Health System. She currently works as a private practice located in Forest Hills, New York. She's a member of the Jewish Orthodox Women's Medical Association, also known as JOWMA, and co-chair of the Women's Health Committee. Dr. Moses, the floor is yours.
Okay, thank you so much for that lovely introduction. I'm very happy and excited to be here tonight. And I'm going to try and share my screen, and hopefully everything works well. Is everyone able to see?
Yeah, I think that's fine.
Okay, perfect. So my name is Denise Moses. I am an OBGYN in Forest Hills, New York. I graduated back in 2017 from my residency at Hofstra North Shore LIJ, and I'm currently practicing, and my patients include both pregnant, postpartum, and reproductive age women, along with women of all ages. So tonight we want to talk about postpartum depression and understand what depression is, what is perinatal depression, what are the risk factors for perinatal depression, how is depression screened for in pregnancy, and can depression be treated in pregnancy? So depression is the most common mood disorder in the general population, and it is twice as common in women as it is in men. So there are many criteria for depression, which Dr. Weinberger will also go into detail about, but basically there's greater than or equal to about 5 symptoms during the same 2-week period that are changed from previous functioning. So people must have depressed mood and or loss of interest or pleasure. And here it talks about, what depressed mood includes. That is, it could be every day, it could be how the person feels, or how they're being observed by others. Loss of interest, weight loss or weight gain without dieting, or a change in appetite as well. It also discusses about children, but we're mostly focusing on women of the reproductive age. Sleeping too much or not being able to sleep at all. What we call psychomotor agitation, so restlessness, etc. Fatigue, feeling worthless, guilt, decreased concentration, and thoughts of death or suicide, including these symptoms that cause clinically significant distress in social, occupational, or other important areas of functioning. These episodes are not attributable to the physiological events of a substance or another medical condition. So basically, they stand on their own, and it's not better explained by another disorder, and there's no history of these episodes in the past. So perinatal depression is when depressive episodes occur during pregnancy and the first 12 months postpartum. It's very common, affecting 1 in 7 women, and can also include anxiety and insomnia. These are the risk factors for perinatal depression: maternal anxiety, stress in the life, history of depression, lack of support, unintended pregnancy, Medicaid insurance, domestic violence, lower income, lower education, history of smoking, single status, and poor relationship quality. And risk factors for postpartum depression: depression during the pregnancy, anxiety during the pregnancy, experiencing any stressful life events during pregnancy, a traumatic birth experience or a birth experience someone didn't expect, a premature baby, or a baby had to be admitted to the neonatal intensive care unit, also known as the NICU, not enough social support, family support around them, prior history of depression, and problems with breastfeeding. So during pregnancy and postpartum, we screen for depression. The most commonly used is the Edinburgh Depression Scale. Some women may have seen this when they go to their doctor's office, and it's basically a form that they fill out, they answer some questions, and it takes only a few minutes. Then, at each OBGYN visit, there's an opportunity to bring up how you're feeling, if you're feeling anxious, if you're feeling upset, if you're not sleeping enough. And seeing the pediatrician after birth, those first few visits, the pediatrician is also a good person that can screen for depression. There are different treatments of depression. Usually the first line is therapy. There are medications that are safe in pregnant and breastfeeding women. So there's no reason to think that you cannot take anything in pregnancy if it's necessary. And you should tell your doctor if you are on any medication prior to pregnancy. When you see your doctor, you should also tell them about your prior pregnancy history. Was there anything traumatic in the prior pregnancy? Was there any anxiety or depression in a prior pregnancy? And all of these things are part of the history in order to better help the current and future pregnancies. If you think you have depression, or if you are not sure about your symptoms, make sure to bring it up to your OBGYN at your prenatal or postpartum visits. And don't be ashamed to discuss your feelings and seek treatment. As OBGYNs, we see this more commonly than people talk about. Thank you very much.
Amazing. Thank you so much. Dr. Moses. And now to go on with our second panelist, I'd like to introduce Dr. Tal Weinberger. Before I do, I just want to remind our audience that we will be answering questions during the last few minutes of the webinar. Please submit your questions to eklein@bpjcc.org. That's eklein, K-L-E-I-N, @bpjcc.org. Okay, so for our second panelist, Dr. Tal Weinberger. Dr. Tal Weinberger, MD, is Clinical Associate Professor and Outpatient Medical Director for the Department of Psychiatry at the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia. She also maintains a secondary faculty appointment in the Department of OBGYN. Dr. Weinberger completed her undergraduate studies at Yale University and attended medical school at the University of Pennsylvania School of Medicine. She's founding director of the Jefferson Psychopharmacology Specialty Services, a specialized outpatient clinic which provides supervision, teaching, and clinical care in the psychiatry department. Besides for the many other great things Dr. Weinberger does, she also serves as the co-vice president on JOWMA's board of directors. Dr. Tal Weinberger.
Thank you so much, Esther, for that great introduction. Thank you, Dr. Moses. I am going to share my screen now. Here we go. Okay, can everybody, here one second. We're gonna start from the beginning. Oops, sorry. Okay, everybody can everybody see that? Okay.
I think that's fine, yeah.
That's good, okay. All right, fine. So we are going to talk more about postpartum depression tonight, kind of to add on what Dr. Moses has already spoken about with you. There were a lot of really excellent questions submitted in advance of this webinar. And I'm going to try to kind of integrate some of them into my talk, and then, there'll be time to kind of address them separately afterwards. But there were a lot of questions about the distinctions between various different issues that we see in the postpartum period. So I want to kind of try to define our terms and talk about different mood and behavioral issues that we see in the postpartum period and kind of what each of them look like and how we would kind of help somebody struggling with each one of these. So the four categories of mood and behavioral issues that I'm going to talk about are the blues, postpartum depression, which is kind of the overarching topic here, postpartum psychosis, and postpartum anxiety. So these are four distinct issues that can occur in the postpartum period that sort of warrant different responses. Okay, so first of all, to talk about the blues is really thought to be it's considered to be a fairly, normal phenomenon. It's unpleasant. Nobody enjoys it, but it's not considered to be strictly speaking, pathological. Up to 85% of women suffer from the postpartum blues, which is basically a mild condition that involves cheerfulness, mood swings, irritability, and anxiety that can occur generally within the first 2 weeks postpartum. Usually it starts within the first 2 to 4 days and resolves within the first 2 weeks on its own. So this is a condition that's mild and lasts for about 2 weeks and then resolves on its own, doesn't require any treatment. Nobody knows for sure, but there is a lot of evidence that, that the postpartum blues are related to normal postpartum hormonal changes, which are occurring in the postpartum period for all women, which is why, we kind of see these sort of minor mood disturbances in most women. However, women who do have the postpartum blues are at increased risk then to go on and develop postpartum depression, although many do not. Okay, so postpartum depression is, and Dr. Moses covered some of this already. I don't think I need to go through all of the exact symptoms again, but really the take home here is that this Couple things. Number one, postpartum depression, like depression not in the postpartum period, persists. It lasts day in and day out for days or weeks. It's not, we sort of set, kind of an almost arbitrary cutoff point at 2 weeks. But really that's mainly kind of just so that people understand that these are not sort of normal ups and downs. This is not just being sad because something difficult happened or even something, a really, really significant loss has happened. This is, sadness that kind of lasts almost all the time, every day throughout the day for a prolonged period of time. Additionally, it's not just sadness. So people with depression will be sad, or will be, kind of not interested in doing most of the things they used to be interested in. But it also does present with some combination of other symptoms. Does not need to be all of these, but people who are depressed will generally have difficulty eating. Either they'll be too hungry or not hungry. They'll have difficulty sleeping. Usually people have a lot more trouble sleeping, but some people will sleep excessively. People will generally, complain of low energy. They won't feel interested in doing the things they're normally interested in. They won't feel like they enjoy the things they normally enjoy. They can have feelings of guilt that are kind of above and beyond what you would, expect, kind of given their circumstances. They may have trouble concentrating, and sometimes they may have suicidal thoughts. Depression in the postpartum period specifically, like Dr. Moses mentioned, can also include anxiety, irritability. Women often feel really very, very easily overwhelmed in when they have postpartum depression. Often women will be like extra worried about the baby's health and safety. They'll kind of imagine all kinds of really, potentially like worst case scenarios, kind of catastrophic things that could happen, to the baby. And again, not every woman has to have all of these symptoms, but it's some sort of combination of some of these symptoms lasting kind of day in and day out for days or weeks. Women who have these symptoms are, obviously distressed by them, and they generally will cause some sort of change in functioning, which can be subtle. It doesn't have to be, that the person is in bed all day, every day. Sometimes it can just be that, people aren't sort of as motivated to do the things that they, that they normally enjoy doing or want to do, or, they just kind of don't, kind of put as much into it. And we generally consider postpartum depression to be depression that occurs anytime within the first 12 months after childbirth. Postpartum depression is the most common medical complication of childbirth. So thinking about kind of all complications of childbirth, postpartum depression is the medical problem that's most likely to occur among medical problems that are complications of childbirth. Occurs in 10 to 15% of women, so about like 1 in 7 that Dr. Moses showed you. Suicidal thoughts are not uncommon, and this is a really striking number. In our, thank goodness, advantaged first world country, where postpartum death is really a very, 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 very rare event, of postpartum deaths, 1 in 5 or 20% of all women who die in an event that's related to the postpartum period are suicides. So 1 in 5 postpartum deaths are suicides. So that's just sort of like, I think, underscores and calls attention to the magnitude and the seriousness of the problem. So postpartum depression is a condition that can be recurrent. If a woman has an episode of postpartum depression or depression during pregnancy, in one pregnancy, the likelihood of them then having another episode in a subsequent pregnancy in postpartum period is much increased. It's not definite, but it's much, much, much increased, and certainly warrants attention and treatment, or not just treatment, but prevention, kind of thinking about like somebody who's had an episode in one pregnancy, what can we do to think about prevention in a subsequent pregnancy, because this is a woman that's at higher risk for another episode. And I'm going to talk about this later when I talk more about treatment, but we do see very clear negative developmental consequences on the baby as a result of exposure to postpartum depression. So some consequences that we see in the literature include, and again, these are in babies whose moms have postpartum depression. There have been demonstrated to be problems in attachment between mom and baby. These moms will breastfeed for a shorter period of time. These babies have been shown to have some delayed motor development in the first year of life, to have poor language and cognitive development, as well as some behavioral problems in the early school years. So this is kind of a good sort of segue into what I'm going to be talking about later in terms of treatment, which is that often the conversation about treatment becomes about the risk of treatment, right? Like if I take a medication, what are the risks to my baby? What am I exposing my baby to? And it's an important part of the conversation. And it's definitely a conversation that every woman should have with her doctor. But another really important part of that conversation that I think often gets overlooked is, what are the risks of untreated depression to my baby, right? So what we've seen really in lots and lots and lots of research and literature over the years is that we really want to think about depression during pregnancy and postpartum in the same way as we think about other illnesses during pregnancy and postpartum. For example, if a woman has diabetes, and we think about the treatment of her diabetes during pregnancy, we want to choose obviously the safest treatment during pregnancy. However, we also need to take into account the fact that if we don't treat the diabetes, we're exposing the baby to untreated diabetes, that we're exposing the baby to elevated blood sugar during pregnancy, which is dangerous in itself for the baby. So untreated illness, it has potential negative consequences to the baby, and treatment also has consequences that we need to think about, and we need to weigh out those pros and cons. So, and obviously in the case of diabetes, we come out in the case, I think we all would agree that we come out in favor of treatment. The same is really true of depression. It's really become very, very clear that exposure to untreated depression during pregnancy and postpartum does have negative consequences for the baby, and that often treatment is safer than untreated illness. So we're going to talk about that a little bit more later. But here are just, again, sort of some of the consequences we see occurring as a result of untreated depression in some babies. So some risk factors for postpartum depression. So postpartum depression does run in families. Women who have family members, especially close family members who have had postpartum depression are likely to be at higher risk for postpartum depression themselves. Depression during pregnancy, like Dr. Moses was saying, is a really, really, really big one. And this is also very, very important because women will often come to me and ask about what they can do to prevent an episode of postpartum depression. What will kind of place them in the in the best position to prevent an episode of postpartum depression. And really often the answer is if that woman is having really any symptoms of depression or anxiety, because anxiety during pregnancy is also a risk factor for postpartum depression and postpartum anxiety, if a woman has any symptoms of depression or anxiety during pregnancy that are untreated, that puts them at much, much, much higher risk for going on to develop more severe symptoms of postpartum depression or anxiety in the postpartum period. In fact, it increases risk by 7-fold. So I will often tell women that we have our best chance of preventing a postpartum episode if we really, kind of optimally treat your symptoms during pregnancy and make sure that you're really, really, really stable going into this kind of very vulnerable postpartum period. Like we talked about before, past history of postpartum depression. So women who have had an episode of postpartum depression are at higher risk for having another episode. And so, kind of should definitely be a consideration in thinking about, preventative treatment. And then stressors are definitely a risk factor for postpartum depression. And this actually, I think, gets to like an awesome question that somebody asked today about thinking about sort of various different factors that, again, are risk factors for postpartum depression. The question related to, is postpartum depression sort of an exclusively biological phenomenon? Does it just, kind of come out of nowhere in, vulnerable women? Or, is there often something else, kind of going on in the woman's life that, that triggers that episode? And, the person who asked that question, I believe is a therapist who had experience in working with women with postpartum depression. And her experience was that a lot of these women really did have a lot of stress in their life. And yes, your experience is accurate and borne out in the data. Absolutely, there are very specific life stressors that have been shown to be associated with postpartum depression, like poor social support, exposure to trauma, medical issues, birth complications. And the way I would sort of, kind of conceptualize this, and the way we sort of, I think about these issues in general is that we kind of have predisposing factors and precipitating factors. So in other words, there are certainly women who, by virtue of whatever, their biology or, whatever, are at higher risk for postpartum depression. We know that these are women who, are kind of going into pregnancy at higher risk than other women because, they have a family history or they have a personal history, or, they have been depressed during their pregnancy. For whatever reason, they're at higher risk for postpartum depression. But not every one of those women obviously is going to develop an episode of postpartum depression. Now, if you layer on top of that these stressors, we think about that as kind of an additional layer that can be more likely to result in the development of postpartum depression. So kind of take somebody who's already vulnerable for biological reasons or for whatever reason, and then you kind of layer stress on top of that, and you've kind of got this perfect storm, which makes the woman kind of even more likely to develop. Okay, so great. So that is postpartum depression. We're going to talk about treatments at the end, but I want to move on briefly to talk about postpartum anxiety, which is related but slightly different phenomenon. So postpartum anxiety, again, I want to sort of think about this similarly to the way we're thinking about postpartum depression, in that, this is not just stress and anxiety, right? I think, a lot of the questions around both postpartum depression and postpartum anxiety kind of, centered around, well, how do I know what's normal and abnormal? And these are great questions, right? Like, how do I know what's the blues? We talked about that a little bit. How do we know what's just sort of, normal postpartum hormones? How do I know what's just, I'm overwhelmed because I have a ton of stuff on my plate and I'm not sleeping, right? Like, how can we tell the difference? Obviously, these are situations where people are, going to be distressed. And so how do we tell the difference between sort of what's normal distress and like actually a diagnosis of postpartum depression or postpartum anxiety? And again, sort of similarly to when we were talking about depression, when we think about postpartum anxiety, or again, anxiety disorders in general, what we're seeing generally is, symptoms that are pretty constant and pervasive and last for a prolonged period of time. So in other words, people who have postpartum anxiety often, are anxious about something. They're not anxious about nothing, right? They'll tell you, like, I'm anxious about, I'm anxious about my baby's safety. I'm anxious about, my other kids. I'm anxious about my financial situation, whatever it is I'm anxious about. There's something, right? It's not just coming out of nowhere. So isn't it normal? Because it's in reaction to to a specific stress, and it's normal to be anxious in response to a stress. But people who have postpartum anxiety or an anxiety disorder outside of the postpartum period will feel anxious almost all the time. And when they're not anxious about one thing, they will be anxious about something else. There's sort of always, or almost always, or often a stressor that's leading to anxiety about something or another. So it's occurring for, like a decent chunk of the day on most days over the course of weeks to months. Again, it may be triggered by a stressor, but in people who have, who have anxiety, postpartum anxiety, or anxiety outside the postpartum period, there's usually some stressor that's causing anxiety. It's kind of the anxiety, it's like a moving target. It moves from one thing to another.
Dr. Weinberger, before we continue, there's
Sure.
noise in the background. If everyone can please make sure they're muted. Can you remove that?
Dr. Weinberger, I think as the host, you can mute them.
Oh, I can?
No.
All right, how do I do that? I'm actually not sure how to do that. I'm so sorry.
I think if you go to participants, go to like mute
Okay.
all.
Do you know which account it is?
Mute all. Okay, got it. Okay. Excellent. All right. Fine. Okay. So continuing to talk about postpartum anxiety. For anxiety in the postpartum period specifically, often the anxiety, although not always, is related to concerns about the baby's safety or health. Often these women will check on their babies to make sure they're still breathing in the middle of the night, will kind of, wash bottles multiple times, will, worry about things that they're eating or that they might be feeding their baby. And again, these are all kind of just examples, but often the worries can be centered around the baby's safety or health. Okay. Sorry. There we go. Okay. Another feature of postpartum anxiety that's quite common is this phenomenon that we call intrusive thoughts. So these are disturbing images that, or thoughts that kind of pop into the woman's head. Often it can feel really like against her will. The content can be violent or really distressing, and the thoughts are not desired and our experience is intrusive. So for example, things that I've heard, a woman who's in the kitchen and sees a knife on the counter and has an image suddenly of stabbing the baby, or a woman who's standing at the top of a flight of stairs and suddenly has a thought, well, what if I threw the baby down the stairs? Or they're standing near the window and they suddenly have the thought, well, what if I threw the baby out of the window? These are the last thing that this woman, in this instance, this is the last thing that this woman wants to do. They're extremely distressing. And they often are associated with a lot of guilt and shame in women who have this experience, who think, well, why am I having these crazy thoughts? Like, what's wrong with me? I must be a terrible person. Like, why would I imagine killing my baby? Like that, I must be a terrible person. And I must be the only person who's ever had this thought. Nobody else could possibly, have horrible thoughts like that. And that will often lead to these women, not disclosing that they're having these thoughts because they fear, being judged or even, being thought of as a danger to themselves or to the baby, or maybe even having the baby taken away from them. And so that's sort of that cycle of guilt and shame then sort of perpetuates the symptoms, and they're not disclosed and they're not, treated or addressed. This is, and we're going to talk about postpartum psychosis in a minute, but this is very important to distinguish from postpartum psychosis, which is a situation where the woman actually really, kind of has, in many ways, like lost touch with reality. She's having kind of ideas that are not reality based, and she might have thoughts about harming the baby in that context. For example, a woman who believes that she is, damaged or evil in some way, and that she's going to harm the baby just, by being its mom. And so therefore she needs to harm the baby or kill the baby in order to, prevent harm to the baby. That's very different from what we're talking about here. This is a situation where the thoughts are unwanted, they're distressing, and they're really experienced as intrusive. They're not thoughts that the woman wants to be having. They're not, they don't fit with anything that she wants. And actually these women in this particular situation, again with postpartum anxiety and intrusive thoughts, these women are absolutely not a threat to their babies at all, although other people who misunderstand their symptoms might perceive them to be, and they might fear that other people will perceive them to be. But this is a very, very important symptom to identify, because again, these women are not a danger to themselves or anyone else, and treatment for anxiety can be really, really quite helpful in reducing or eliminating these thoughts. Okay, so postpartum psychosis, again, this is different. Postpartum psychosis is very, 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 very rare. But often when we hear these sort of horrific stories of moms harming their babies, not always, but it's certainly in some cases, postpartum psychosis is involved. Postpartum psychosis occurs in 0.1 to 0.2% of the population. So it's a very, very small percentage of the population. It is often, but not always, associated with bipolar disorder. So women with bipolar disorder are at higher risk for having postpartum psychosis, and somebody who has had an episode of postpartum psychosis is at higher risk for then going on to develop bipolar disorder, although that's certainly not guaranteed. Often with postpartum psychosis, we see very, very, very rapid onset of symptoms. So these women can go from being fine to being really very, 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 very ill and impaired and confused within 2 to 3 days after delivery. They kind of go from being themselves to being, somebody who's really, really very much out of touch with reality very, very quickly. This is a psychiatric emergency. So when we say psychosis, what we mean are ideas that are, again, sort of not in accordance with reality, and where the woman can't be, talked out of them or, convinced to doubt them in any way. So, for example, my neighbors are tapping my phone or spying on me and want to harm my baby, and so therefore, I need to harm my baby to prevent my neighbors from harming my baby, that sort of thing. Or like the example I said before, a common one is women will, have this belief that they are in some way like dangerous or damaging to their baby. And that, unless if they harm themselves or harm their baby, they're going to continue to, kind of do some sort of permanent damage to their baby. And, this is a belief that's, again, not based in reality at all. And these women cannot be convinced or talked out of these beliefs. Sometimes these women can have what we call hallucinations, meaning that they hear voices or see things other people don't hear or see. Sometimes this can be associated with kind of odd or even, what we call grandiose beliefs. So, sometimes, women with postpartum psychosis will believe that they have special powers or talents. They might believe that they're Mashiach, or that they, are hearing direct messages from Hashem. They might, they can speak in a very, odd, disorganized manner sometimes. And the important things to keep in mind is the symptoms really can change rapidly. And that's part of the reason why this is so dangerous, is that these women can actually, have periods of time where they look fairly normal. And then, their loved ones will say, oh, well, okay, they're really just fine. This was really nothing. They seem like they're okay. But again, these women can, the severity of their symptoms can fluctuate very, very rapidly with time. And just because they have kind of a period of time where they're appearing more normal does not mean that, that they're not in an episode of postpartum psychosis and that things aren't going to get worse again. This is a psychiatric emergency, usually requiring hospitalization. There is actually, a significant risk of danger to the mom or to the baby with untreated postpartum psychosis. Again, because the mom is really not herself and really has, it has lost touch with, with reality. Okay, fine. So now we've covered kind of those 4 areas. And now I want to go on to talk about treatment. So like we were talking about before, it's really important to treat symptoms of depression and anxiety during pregnancy and in the postpartum period. Number one, right, we talked about treating symptoms during pregnancy to prevent worsening of symptoms in the postpartum period, which we know, is a very, very significant risk. The other, issue that, that we talked about that we'll talk about more is how symptoms of depression and anxiety, both during pregnancy and postpartum, actually really can cause harm to the baby. Often women will think, well, I'm going to just, I'm going to suffer with my symptoms of depression because I don't want to expose my baby to medication, without knowing that, in fact, they're then exposing their baby to untreated depression and anxiety, which itself has negative consequences to the baby. So, treatment can help prevent those negative consequences potentially. And then, just to reduce suffering and impairment. These women are really suffering, a lot, and treatment can be really, really helpful in reducing suffering. So treatment, like Dr. Moses was saying, psychotherapy is a really good treatment for mild to moderate depression. There are some specific forms of psychotherapy that have been kind of specifically, tailored to address kind of issues that women commonly face during pregnancy and the postpartum period. Specifically, two types of therapy, that have evidence for efficacy during pregnancy and the postpartum period are these types of therapy called cognitive behavioral therapy, or CBT, and interpersonal therapy, or IPT. And so those can be, absolutely very, very effective treatments. However, there were a lot of questions about sort of lifestyle changes and alternatives to medication for treatment. And these are all very, very reasonable questions. Sleep is very, very important. And sleep is obviously, something that's really tough in the postpartum period. But, maintaining regular sleep to whatever extent is possible is, and enlisting other family members, husbands, other people to help try to preserve sleep regularity can be quite helpful for some people as well. Sleep disturbance and depression are very, very interconnected and can certainly lead to one another. Exercise in some studies has been shown to be helpful with depression, specifically, during pregnancy specifically, and in the postpartum period, and depression in general. However, the important thing to keep in mind is that medication can be used. We have a lot of reassuring data about the safety of medication in pregnancy. Medication can be used in a way that is safe, and we don't want women to, kind of keep on trying treatments that are not helpful in the interest of avoiding medication. So certainly, depression with mild symptoms, psychotherapy can be helpful. Exercise can sometimes be helpful. Sleep can be helpful. But often by the time people come to me, they've tried those things and they haven't worked. And then they're feeling kind of extra doubly guilty. Then they're saying to themselves, what's wrong with me? Like, I'm trying these things that like people say work for depression and they're not working for me. Like, what's wrong with me? That means I must be even like more damaged than I thought I was. And then that can sort of become like another vicious cycle. Sometimes these treatments, aren't effective, and medication is necessary. And medication absolutely can be a first option for women who do present with more significant or severe symptoms, women who have had a good response to medication in the past for depression, either during pregnancy or postpartum or at another point in their life. When, kind of these other things aren't helpful enough, somebody's tried psychotherapy or they've tried exercise and it's just not, it's not working well. And what I actually see quite frequently is, therapists will refer patients to me and they say, I'm trying and the patient's trying, the woman is really trying really hard and I'm trying really hard. but it's just not working. And sometimes what happens is that the depression is sort of sufficiently severe that, you know, the woman really just needs to get her head above water in order to even benefit from the therapy. And that's where we see medication and therapy working together very, very effectively. You know, sometimes we kind of just need to turn down the volume on the symptoms sort of enough that the woman can kind of access the therapy and, you know, and use it. Similar for something like exercise. You know, if somebody is so depressed that they can't exercise, we can't really tell them to exercise. It's not helpful. But if they're feeling a little bit better, then they might be able to exercise. And then, you know, if we bring down the volume of their symptoms with medication, they then exercise might be something that they can do and can be helpful. And the goal of treatment during pregnancy is really to achieve and maintain normal mood. So a lot of times women will say, I'm feeling good enough. You know, you put me on this low dose of medication and it's kind of helping a little bit. I don't want to increase the dose any higher. I want to be on the lowest dose of medication possible. And that's unfortunately sort of, leads us to kind of the worst of both worlds, because then what we're doing really is we're exposing the baby to both medication and untreated maternal illness, right? So there are symptoms that are left over, and there's also medication. There's really no evidence that higher doses of medication are associated with any, with any specific problems, more so than lower doses of medication. And so if we're using medication, if we've decided that, that it's important to use medication to treat depression, we want to make sure we're using it to really get the woman's symptoms under control as much as possible. Okay, so again, benefits of treatment generally outweigh risks. The exposure to untreated depression is not benign. Antidepressants have really been studied very, very extensively during pregnancy. They're probably the best studied medication during pregnancy, and most of the safety data we have is reassuring. And really, we have no consistent evidence that there is an association between any antidepressant and birth defects, with a possible exception of a medication called paroxetine, which there's some conflicting data on it, but be that as it may, that's generally not our first choice regardless. It's not a medication that we can never use, but other medications, there's really no clear data associating any of these medications with any specific birth defects. Studies that have raised concerns about antidepressants, and I'm just gonna try to say this quickly because I want to leave time for questions. Keep in mind that whenever we're studying an antidepressant, like in a study, when we're looking at effects of medication on a pregnancy, on a baby, we're also by definition, again, studying the effects of the illness, right? So like any woman any baby who's exposed to an antidepressant is also by definition a baby that's exposed to depression, right? A lot of the concerns that were initially raised in some of the earlier studies about antidepressants, which raised some concerns when the data was looked at more closely, it actually seems for most of these cases that the association is between depression and the outcome rather than the medication and the outcome. This is, a good example of this are the studies on autism. There was a lot of concern about autism being associated with antidepressants. A lot of people were really very, very concerned about that. There were some studies that raised some legitimate concerns, but when that data was looked at more closely, what was found is that antidepressants do not cause autism. They're not associated with autism. But in fact, there are some common genetic factors between depression and autism. And so people with depression may just be at a higher risk for, autism, or having, a family member with autism. And so again, the association was with the illness rather with the treatment. So taking antidepressants does not increase the risk of autism. Okay, so most effective medication is the safest medication. We want to make sure that we're using a medication that has been helpful. Like if a woman has been helped by an antidepressant medication in the past, that is the medication, you know, in almost all cases that should be maintained during pregnancy. And like I said, there's really no evidence of any association between dose and any concerning outcomes, and the dose should be increased till the medication is most effective. And then really quickly talking about breastfeeding, antidepressants are among the most frequently used medications by breastfeeding women. Exposure actually during breastfeeding is much, much lower than exposure during pregnancy, which, you know, we already know is something that we can treat women during pregnancy, you know, safely. Most antidepressants are present in very, very low levels in breast milk. There are some antidepressants that are present in slightly higher levels, but there's no evidence that the ones that are present in higher levels are any more dangerous for the baby than the ones that are present in lower levels. So again, we want to make sure that you know, when we're treating in the postpartum period, we're using an antidepressant that's been helpful in either past or current treatment. If, you know, if the woman's never tried an antidepressant before, then, you know, then we can really pick any one. And then often we'll pick one that, you know, is present in very low levels in breast milk. But a much more important consideration is a medication that's been effective. We do not want to start experimenting with new medications in the postpartum period. I cannot tell you how often I have seen women who are switched from an effective medication to a medication that, you know, a very good intentioned psychiatrist or OBGYN thinks is a safer medication, only to have the, you know, the woman relapse because the medications are not interchangeable and the one she was taking before was working, whereas this one may not work for her. Okay, so, and then I just want to wrap up with some resources, and maybe you know, I can just leave this on the screen. I want to make sure we have some time for questions. I practice in Philadelphia, so I'm not really familiar with the New York resources, but there is this wonderful organization called Kimpaturin Aid, which provides crisis intervention, housekeeping, baby nurses, furniture, meals, etc. The Motherhood Center, which is in New York, does have virtual support groups. Yad Rachel is a wonderful organization in Lakewood, and so the information for that organization is there. They have a helpline. There's going to be an office opening in Muncie in September. And then Postpartum Support International is a wonderful organization that I actually do have some personal knowledge of. They have online support groups as well. They have a helpline. And then they are really trying to get people, you know, coordinators for various different cultural needs. So recently, and this is not even on their website yet, but they did hire a new coordinator for the Orthodox community. And you can call PSI and ask to speak to Rena. Her contact information, which I was given permission to share, is up on the slide. And then there is a provider-only helpline, which I'm actually involved in. I'm one of the consultants on the provider-only helpline. What that is it's a number that providers can call into. So, you know, it's only for physicians or nurse practitioners or physician assistants, people who are providing care. But often what will happen is that, you know, that providers are treating pregnant women and don't feel comfortable, you know, and don't necessarily feel like they have the knowledge to, you know, to make good decisions in treating pregnant women. And so, and you know, I'm sure a lot of people have had this experience where their doctor said, well, I just don't know if this medication is safe, or I think you should stop this medication because they don't know if it's safe. And this is a helpline. You can tell your doctor to go to the PSI website and call this number, and they can make an appointment with one of the consultants at PSI. I'm one of them. And they will have an appointment scheduled where your doctor can discuss your case, obviously anonymously, and get advice from the consultant, who can then, you know, tell the doctor, you know, yes, this medication, you know, I would continue this medication, or I wouldn't continue this medication, or this is kind of what I would advise, kind of based on my expertise. So I'm sure that many of you have encountered this situation. Many people have with their doctor where they're really just not sure what's safe during pregnancy. Please tell them to call the PSI helpline and make an appointment to speak with one of our consultants. And that is it.
Thank you, Dr. Weinberger. That was truly eye-opening. Thank you so much. We have a couple of questions that came in. And if anyone else has any questions, please feel free to send them in to Klein, E as in Edward, Klein, Klein, at bpjcc.org. And send them in so we have time to cover them soon. Okay, so the first question that came in, and I think this is a question for Dr. Weinberger, can one with psychosis know that they are dangerous for the baby?
I mean, the problem is that often they don't, right? Often, you know, the woman who's experiencing psychosis is, you know, is really detached from reality and is kind of in a reality of her own, such that she's really not able to have the insight to recognize that her thinking is impaired or that she could potentially be a danger to the baby, which is why this is such an emergency, and why, you know, we often need to hospitalize this woman and protect her baby until she's well again, and able to kind of have that insight.
Thank you. And I guess this question goes to Dr. Moses. Somebody is asking if they had postpartum depression and they want to ensure that they don't have it again. What should they do before they get pregnant?
Definitely talk to your OBGYN prior to getting pregnant. Talk about if you had to be on any medications. Are you on any medications currently? Is there a psychiatrist involved? You know, and kind of loop everybody in together so that these conversations can be had prior to pregnancy.
Great, thank you. Okay, I'm not sure what this question is. Let me. Okay, I'm just going to try to read it off. Maybe you can understand it. Can one have postpartum depression after almost 2 years after birth? Oh, okay. So she's asking if somebody can develop a postpartum depression 2 years after giving birth. Assuming postpartum depression was there all along and was just left untreated, and now 2 years after, like, she's realizing that.
Yeah, so then absolutely. So then it, you know, it didn't develop 2 years after birth. It developed, you know, sooner in the postpartum period, and it just, you know, wasn't addressed until then. But yes, I think, you know, it sounds like, if I'm, you know, the question that's being asked is, does postpartum depression persist if it's untreated? And the answer is yes, it can, and it can get worse, and it can get actually harder to treat with time. And so it actually can be really, really important to address it early. But, you know, depression is treatable at any point in its course, right? So if at any point you're sort of realizing that, you know, that this is a problem that you kind of hadn't recognized before, or your loved one is having this problem that they hadn't recognized before, you know, seeking treatment really at any point can be really, really helpful and effective.
It's really important, I'm just going to add, to be an advocate for yourself. Sometimes you have to think about, you know, I have to mention this, I have to talk about this. Don't be ashamed, don't be embarrassed, don't think anything's a dumb question, just ask, because the more you know, it's just going to help in the long run in terms of if treatment is necessary. And then treatment can be started sooner, which, like Dr. Weinberger said, it's going to get harder to treat as the problem goes on.
Right. Okay, so another question. I guess somebody wants to know if can postpartum depression just be an imbalance with no triggers? I guess she just wants to know, like, can postpartum depression just develop out of nowhere without any triggers? I guess she's asking if it could just be a chemical imbalance.
Absolutely. Yeah, no, absolutely. And we see that all the time. When we talk about risk factors, what that means is that, people who have those risk factors are at higher risk, but it doesn't mean that somebody who doesn't have a risk, a specific risk factor can't develop the disorder. And absolutely, we see all the time people who really, they'll say, there's nothing wrong with my life. I'm fine. Everything's fine. I'm happy. Otherwise, I was happy otherwise. And I just sort of developed this depression out of nowhere. And I don't know why. I can't identify a specific trigger. That certainly can happen.
Okay, I have another question here, which might be a little bit case specific. So again, if you have a specific question, I would suggest everyone speak to their own OBGYN, but I'll put it out there and maybe one of these can help her. She says, I take a low dose of Lexapro for postpartum depression for my last pregnancy. My, provider told me I can take antidepressants during pregnancy. So either I can stop the antidepressants or not get pregnant. She wants to know if that's correct advice.
That's very unfortunate. I don't know, Dr. Moses, do you want to take this? I feel like I've been hogging.
Can I actually share my screen really quick? I have a very good chart.
Sure, Dr. Weinberger.
Oh, sure. Sorry, I need to make you host.
I know it's a little process.
Okay, you're good.
So this is from ACOG. Basically, I'll just pull it up if I can. Nope. There we go. Okay. So basically what it does is it talks about medications that are used in pregnancy and lactation. And it talks about anxiolytic medications like the Xanax and things like that. And
I'm sorry, Dr. Moses, I think you've got something else up on your screen. It's a different email.
Oh, sorry. Hold on. I obviously don't know how to work this. Hold on. I apologize.
Well, while Dr. Moses is finding her chart, I just want to say Lexapro is a medication that we have a lot of reassuring safety data about. There's no evidence that Lexapro is dangerous during pregnancy. There are, considerations to talk about that you should, certainly talk about with a knowledgeable provider. But I have maintained many people safely on Lexapro during pregnancy. And so, so I don't agree with that advice. And I think it's unfortunate that people, I think are getting advice such as that. And I think that would be actually a situation where you might, direct your provider to the Postpartum Support International provider helpline, where they can get, advice from a reproductive psychiatrist, again, which is a psychiatrist that works extensively with women during pregnancy and postpartum, and who's really familiar with, with the safety data, and your provider can get accurate advice.
Exactly. Is the correct chart showing up now?
No, I'm sorry.
I think you're sharing your email versus your screen. Maybe stop sharing and then try it again.
So weird. I apologize. It's supposed to share this one.
There should be an option of stop share, and then you can reshare your screen.
Okay. Sorry. I really just want to show, like, there are so many medications that are okay to take in pregnancy. Here we go. Now, are you guys seeing it?
Yeah, now you got it.
Okay. So here we go. Sorry about that. So basically, there's these anxiolytic medications that are safe to take in pregnancy, which are not safe to take, which are like category D and category X, so like Xanax and those type of medications we really don't want people to take. But then you have these antidepressants and, the medications that someone had mentioned, which is Lexapro, Prozac, Zoloft. These are all known medications that are given in pregnancy that many patients are on that are okay to take in pregnancy. And then there are these antipsychotics that are very well known as well. So it's really something to talk to your doctor about, your OBGYN, your reproductive psychiatrist, because those are the people that know these medications well, as opposed to having someone who's not really so involved in the reproductive age, just saying, don't take anything. And then it kind of puts people in a more difficult situation of being pregnant and having depression, or dealing with postpartum depression and breastfeeding, etc.
And again, like, just to add to that, remember that getting pregnant and coming off medication and suffering from untreated symptoms, there's some very, very clear data that that's not safe for the baby. And that's less safe than exposure to, these medications, which again, we have a lot of really, really reassuring safety data. The chart that Dr. Moses has put up, those sort of letter gradings, those are sort of safety gradings that can be helpful, but aren't really used anymore because they don't really provide kind of enough information. Like, for example, some of the medications that are category C, are medications that we really have a lot of reassuring safety data about, and we use without feeling concerned about them. Even some of the medications up on top, the benzodiazepines, the ones that are category D, many of them in appropriate situations are medications that we absolutely can use safely. And they're not medications that, are necessarily our first choice, but they are medications that kind of under the right circumstances and with the right, knowledge can be used safely during pregnancy.
So the main thing is to just talk to the doctor, talk to the psychiatrist, talk to your OBGYN, and just get more information. If you shut it down, then you're losing out on possibly a good treatment and having a healthy pregnancy.
Amazing. Thank you so much. Okay, I think we're just going to take one more question. A lot of really great questions came in, but I don't want to keep you for very long. So we're going to take one more question. And then if anyone has any further questions, please feel free to reach out to us, and we'll try to answer everyone according to case by case. Okay, so the question is as follows. If I had postpartum anxiety after my previous birth and I'm pregnant now 7 months, but feel amazing, would you recommend that I talk to a doctor about getting onto medication again prior to giving birth in order to prevent postpartum anxiety?
I'm happy to take that, unless if you want to, Dr. Moses.
I think that you can talk to your doctor, but the possibility of starting medication if someone is feeling okay is not really likely. We would wait for symptoms to start, or if some other issue was coming up, then we would start medication, but we wouldn't start medication to prevent that from happening if that happened previously and you're not having any symptoms now.
So I have a little bit of a different perspective, again, because, because we know that women with a history of postpartum symptoms really are at much higher risk for developing postpartum symptoms. There are sort of two schools of thought in terms of prevention. There are some doctors that will start a medication, kind of preventatively at the end of pregnancy or immediately after delivery to try to prevent symptoms that we think are likely to that the woman is really at high risk for, for developing the symptoms again. Some doctors will, wait until, there start to be like, very, very mild, subtle symptoms. Like if this is somebody who we feel like is reliable to sort of monitor for very mild, subtle symptoms, we might wait until those emerge if that's what the woman prefers in order to treat. But in many cases, I have practiced this way on many, many occasions that, in somebody that we think is at high risk for developing symptoms. And, we know that they've tolerated medications before, and we know that we can use the medication safely. We might start a medication preventatively. That would be a very reasonable approach.
And that's why it's good to talk to both the OBGYN and to the psychiatrist.
All right, thank you both so much, and thank you everyone for joining. I hope this was as eye-opening for everyone else as it was for me. And yes, if you have any further questions, please feel free to email me at eklein@bpjcc.org. Have a good night. Thank you.
Thank you.
Thank you, everybody.